Hello everyone, and welcome to the second of two webinars by the Scottish Drugs Forum and Waverley Care to mark World AIDS Day 2020. We're going to hear from four speakers today, where the running order is we will run till 4 o'clock. We'll have two speakers and then a 10-minute break around 3 o'clock. You can send your questions throughout the webinar by using the questions tab, and the question tab appears on the control panel, which should be on the right side of your screen. And just to let everybody know, this webinar has been recorded. So I'm Fiona Gilbertson, your chair for today's webinar. Yesterday, as everybody knows, was World AIDS Day. I always find that quite emotional. I was diagnosed with HIV in the 1980s, and imagined through working with various different charities and organisations that we would be not still having outbreaks and having to have these kind of conversations. We've just had an outbreak amongst our, well, we're in the midst of an outbreak, as everyone knows, of HIV among one of the most vulnerable populations in Glasgow, people who have no homes, who are using drugs. I don't even know what to say to that, except as my role as founder and chair of Recovering Justice, we promote safer drug policies and hope that Scotland will implement decriminalising drug use, create safe and regulated drug supplies, housing, access to treatment, and that we will all be able to work together to promote that. This is a completely avoidable outbreak, and we all know how HIV is transmitted. So in 2020, it's just, for me, devastating to see that this is still happening. What I would now like, we've heard last week SDF talked about the approaches that have been taken in Athens, Dublin and Romania to respond to and tackle localised outbreaks. And you can now view this on SDF's YouTube page. And I'm really proud to be presenting these speakers. Frontline work is so vital and so traumatizing to do, let's be honest. And the people that do it, I know that from receiving frontline work, is like it's life-changing. So I'd like to introduce you to our first speaker, who's Colin Gibson. He's the bloodborne virus outreach and the clinical nurse specialist at the Brownlee Outreach. And Colin, it's over to you.
Okay, thanks Fiona. So my name's Colin. I'm one of the bloodborne virus nurses here at Hunter Street. So the first couple of slides here I'm going to talk you through is basically an outline of what's been happening. So this is the largest UK outbreak in this population for the past 30 years. And as Fiona said, it's absolutely associated with homelessness, incarceration, injecting cocaine and injecting in outdoor locations. This outbreak started in 2014. So far there's been 187 people diagnosed with HIV in this population, and we've had 39 people have died. However, I would like to point out that those 39 people that died, it's not HIV related, it's other reasons that they've actually died. Okay, if I can have the next slide. Okay, so this is just looking at what's happened then, where we were then, and where we are now. So then it was absolutely, there was nothing really set up for this specific population. It was centralised hospital-based outpatient services. The attendance levels at appointments was very low. Adherence to the antiretroviral therapy was poor. Testing amongst this population was approximately 30% at that time. The antiretrovirals were available from either the hospital pharmacy or home delivery, which is still the case, obviously, for many people, but not for our client group, really. Time to consultant appointment was between 4 and 5 weeks, which is quite a long time, and time to start an HIV treatment was 3 to 4 months. So that's where we were in 2014. Now in 2020, things have changed quite considerably, I would say. We started the Glasgow Care HIV outreach, so GECO was implemented, and from there we've got bloodborne virus clinics are now held within the Homeless Health Service building where I am today. We do a lot of outreach work, which I'll talk about later. 95% of people have a viral load less than 200 copies, which is very significant. That's a great result. HIV testing is approximately 50%. That was in 2017, 2018. I don't have any more recent figures than that, unfortunately. And antiretroviral therapy is available from hospital pharmacies and from community pharmacy. So that's just a brief outline of where we are now and then. I'm going to go on to my actual talk, looking at what we do as bloodborne virus nurses and the bloodborne virus outreach team. So next slide, please. So here we are. So we're very fortunate. We've got 2 consultants, Dr. Peters and Dr. Metcalf, one coming from an infectious diseases background and the other from sexual health. So that's very lucky for us. And then we've got the 3 nurses there and a healthcare support worker. So we've got a combination of bloodborne virus and addiction experience as well as third sector experience, which is brilliant. So it really is multi-agency working that we have nowadays. We're constantly in contact with the Brownlee Pharmacy, absolutely. We've got third sector, one of our third sector colleagues is going to talk to you in a wee bit. We're very involved with the addictions teams as well, and sexual health is on just after me. So that's all very important. So I'll go on to the next slide, please. So, okay, what do we want? Well, ultimately, what we want to do is we want to treat our patients and we want them to be well. There's a lot of benefit for with getting treated for your hepatitis, for your HIV. There's still issues with HIV. You can still become very ill. You can still die with HIV, but the treatments nowadays are absolutely excellent. They really do work, and it can be as little as 1 pill once a day. But obviously, you need to take that for the rest of your life. So to start off with, we need baseline bloods. So we need to check for HIV resistance, and we need to check for bloods to see if they will have an allergic reaction to some of the medications. And there's other baseline bloods. We need renal function, etc. And then, of course, we need the patient to agree and to tie into the actual treatment. So that's at the start. And then we need to go on to maintain their treatment, keep them on their medication, make sure that everything's going okay. And then obviously we want to reduce the likelihood of HIV transmission. So we've got U equals U, so that means if you're undetectable, then it's untransmittable. But that's talking about sexual transmission there. We've also got TAS, which is treatment as prevention. So we don't really have a level of data for injecting, but we can say that reduction in the viral load translates to a reduced risk of onward transmission. So that's really what we're aiming to do to prevent others from actually catching HIV. Okay, so I'll go on to the next slide, I think. So what's the problem? So obviously there's lots of problems in this specific group. Problems with engagement, just trying to develop trust with our clients, trying to get them to adhere to the medication. There's always the problem of stigma with HIV and other bloodborne viruses. Other problems are lifestyle factors such as drugs and alcohol intake, and also just basically accommodation and where are people going to sleep that night. That's always going to be a problem. So can I go to the next slide, please? So what do we do? So we do outreach. This is key in our work. It really has helped us gain access to our clients. We can outreach to all sorts of different places. So obviously here in Glasgow, we go out to Greenock and Paisley as well, and wherever really we need to. We outreach to people who are begging on the streets as well. If they're at the hub, lots of opportunistic outreach, just trying to get ourselves involved with our clients. Sometimes we don't see them for a long time, and so we'd have to do anything we can to engage them. And we do a lot of phlebotomy and other healthcare issues during our outreach. We also need to try and develop a relationship with our clients, try and get them to trust us, and trying to get them to turn up to their appointments, which would be great, and to take their medication, which is ultimately what we want to do. So we've got different clinics that we run. We've got a clinic here in the homeless addiction unit in Hunter Street. We also run a clinic in Paisley, and also in Brownlee at Gartnavel, and also in different prisons. Okay, I can go to the next slide. So what else do we do? Okay, so there's always issues with regards to patients getting to their appointments. So we can provide a limited amount of transport. We can, as we're able to prescribe as nurses, we're able to prescribe with HIV medication as well as other medications that they may need sometimes, maybe a course of antibiotics or iron tablets. We're always in close contact with their GPs if need be. And we can also look at co-infected patients. So if they're co-infected with hepatitis C, then certainly we can go ahead and treat that. And we actually offer FibroScans here at Hunter Street as well. Okay, so let's go on to the next slide. So are we making a difference? So yes is the short answer. So now, previously at the beginning in 2014, patients were seen in 4 to 5 weeks of diagnosis, and then they were started on treatments up to 3 months later. So that's quite a long gap there. However, now patients are seen within a week of diagnosis, and they are started on their treatment within 1 to 2 weeks from diagnosis. So that's a real achievement there, and that improvement is due to the way that we work, really, ourselves and obviously our colleagues elsewhere. We've got better access to patients. Patients can adhere to their HIV medication. We don't wait to start people on medication, we just start people. We don't wait for them to be stable or whatever. We just need to get them started as soon as we can, and we need to provide support to make sure that they do continue on the medication. And also the medications nowadays are very good and are quite robust. So it means that resistance to the medications is less likely to occur, which is a great thing. Okay, so I'll just quickly go into my final slide. So this just looks at viral suppression. So you can see since 2014 how that's actually improved, and I think so far in 2020 you can see that we've got 95% achieving viral suppression. So that's another great achievement. So it looks like what we're doing does work. Okay, so that's me finished. So I'll hand you back to Fiona.
Thank you very much, Colin. And hold on. I will hand you now over to Lindsay Boyd, who's the Sexual Health and HIV Outreach Nurse at the Sandyford Hunter Street Homeless Health Project.
Hi, thanks Fiona. Yeah, I'm Lindsay. I'm one of the sexual health nurses from Sandyford Sexual Health Services, and I'm based within the homeless addiction team in Glasgow City Centre. So thanks to Leslie and SDF for inviting me to talk about how sexual health and HIV prevention services adapted to address our role within the HIV outbreak among people who inject drugs. Next slide, please. So in March 2018, myself and my colleague Caroline were asked to carry out HIV contact tracing among those who had been affected by the HIV outbreak. Some of this had already been done by the Brownlee HIV service, but as Colin described, when their delivery of care changed from hospital-based to community-based, some people were now being missed in terms of their partner notification, or their contact tracing as we call it. Initially we did this once a week, but quickly realised the scale of the task, and by October 2018 we were both based fully within the homeless addiction team at Hunter Street. We started back at the beginning, and to date we believe we have carried out contact tracing on every active patient in the cohort now, and we have also tested or arranged testing for the majority of the contact information that we've been given. With the move to the homeless addiction team, we also noticed a gap in the sexual and reproductive health care within this community. Many weren't travelling to the out-of-town services provided by Sandyford, but they did require our support, especially with things like long-standing genital symptoms, contraception provision, and past sexual trauma. Access to services should be equitable, so being based within these services dedicated to anyone with addiction issues has allowed us to develop and shape services to suit the needs of this at times complex population. We offer a variety of locations across the city. We do weekly clinics at the Glasgow Drug Crisis Centre and the Simon Community Access Hub. We do targeted visits to patients within various homeless accommodations, plus, as Colin described, we also do assertive street outreach as required. Our team currently consists of Dr. Rebecca Metcalf, who is our consultant and a fantastic support to us. We also have 2 Band 6 nurses and 1 healthcare support worker. Next slide, please. The HIV contact tracing can be particularly challenging within this group. A recall of events in particular can be diminished by drug and alcohol use, and it also needs to be revisited and repeated regularly if they've fallen out of HIV treatment and have had sexual or injecting contacts while off their medication. For this, we try to use different approaches, such as asking who was around at the time rather than specifically who they may have shared injecting equipment with or had sexual contact with. We can offer as well a provider referral model of partner notification, where we get in touch with named contacts directly and let them know we believe they may have come into contact with HIV. This allows patients to remain anonymous and allows them to choose to keep their HIV diagnosis private to them, but it also allows us to offer testing and provide support at the same time. We do venous blood, dry blood spot, and point of care rapid HIV tests. Within the community, we also offer PrEP, HIV prevention medication, to those at sexual risk of HIV and who are eligible for PrEP, pre-exposure prophylaxis under the current guidelines. Most fall into either category 1, which is a sexual partner with a detectable viral load, or category 4, an individual at an equivalent risk of HIV. So category 4 for us covers both those having unprotected sex with another PWID or anyone involved in transactional sex. We also adapted our usual method of medication delivery in line with the Brownlee service and can provide PrEP daily alongside ORT dispensing at pharmacies. As well as contact tracing and PrEP, we also provide routine sexual and reproductive health care, such as contraception and smear testing. And we also include assertive annual recalls and smear testing for HIV positive women to ensure that they're not missed at all of the outreach locations that I previously mentioned. Next slide, please. So just wanted to talk a wee bit as well about how we then adapted our service during COVID. Things became particularly tricky for all services across the NHS, but during the first COVID lockdown, up to 600 people were accommodated within the city centre hotels, and we were receiving referrals from staff and direct contact from patients who were reporting an increase in sexual activity and injecting episodes, including sharing of injecting equipment. We were also hearing about increased reporting of sexual assaults. To us, this information suggested a potential increase in HIV transmission risk, as well as all the other sexual and reproductive health needs that came along with that. When face-to-face clinics closed, we wanted to find a way to still be able to provide our HIV prevention and sexual health outreach services. So we were given access to the mobile injecting equipment provision van, which you can see here. This is me in the driving seat with my colleague Lisa, who we worked regularly together along with other members of the team during COVID. The van we were able to use as a clinical space during the day. We travelled every day to many locations across the city centre, including hotels and pharmacies, to offer our support, really with a focus though on BBV testing, contraception provision and PrEP. The feedback from services was really positive and the patients absolutely loved it. What's not to love really about a clinical space driving up outside your accommodation? We also worked in partnership really well with other services, including Colin and Lynn and the HIV treatment team, and also the city centre outreach team, who were able to facilitate quick access to ORT and wound care. Next slide, please. So that's really just a brief overview of how sexual health services fit into the PWID HIV outbreak in Glasgow. I hope you've enjoyed listening to what we get up to day. It's a very busy job, but it's exceptionally rewarding. Thank you.
Thank you very much, Lindsay. And we're actually going to just go straight to our next speaker, who is Rebecca Blair, and she's the Advanced Clinical Pharmacist at part of the Phoenix team for NHS Greater Glasgow and Clyde.
Thanks for that, Fiona. So my name is Becky and I'm one of the pharmacists for the Phoenix team. We are the Pharmacy Homeless Outreach team and we work in the Glasgow City Centre. The Phoenix team is a very small team. We are just 4 pharmacists, 2 admin staff, and we are working with support workers. These are normally from the Simon community and the Marie Trust. So I'll tell you about that in a sec. Can we go on to the next slide, please? So as I mentioned, we're a small team. We are fortunate to work in partnership with the Marie Trust and Simon community. Our service is a health and a social prescribing model. We are an outreach team primarily. We work over various venues, whether that's the Simon Community Hub, the Marie Trust building, or due to COVID, we now work over quite a few of the homeless hotels in the city centre. We also take referrals from other services, which is great for partnership working, whether that's our colleagues over at Hunter Street, up at the Royal, over at the Brownlee or at Sandiford. So we're very fortunate to do a lot of team working, which we find helps get patients linked in with services very well. The bulk part of our service is to offer a health and social prescribing model, and part of this does include HIV testing. We find that sometimes patients aren't quite ready to engage with that part of our service, so we are quite fluid. We offer a health check, which is about 15 pages long, so it is quite a wide service, and HIV is one of the parts of that. The little kind of screen there you can see is the kind of questions that we go through with our patients if they present wanting a bloodborne virus test. We offer the dried blood spot testing as part of our service, and that's if the patient wants it. We tend to find sometimes that they're not always ready. Most of the patients that we work with are homeless or at risk of homelessness. So sometimes they have different priorities and maybe aren't ready to engage with their HIV or Hep C status, in which case we take things at the patient's own pace. We sometimes find that when they first engage with us, they've got a different priority. in which case we go with the flow and we work at the patient's pace. They might find that on appointment 1, their main concern is maybe getting their inhaler because they've lost it when they've been moving around accommodations, in which case we would get a prescription sorted that day, and we're all prescribers, which helps. And then we basically link in with the patient for as long as they're wanting to access our service. It might be that on appointment 1 we do their inhaler, appointment 2 we address their addiction issues, and maybe appointment 3 they're ready in a position to get their HIV or Hep C status tested, in which case we'd offer the dry blood spot test at this point. We basically do find that it's working with the patient at their pace, and when they're ready is quite a fluid service, so it's basically just adapting. Like my colleagues have mentioned, one of the problems is kind of accessing patients sometimes if they're moving around, and maybe just waiting for the patient to be ready to want the test as part of their service. As Lindsay and Colin have mentioned, with COVID, a lot of people are now in the hotels, and the recent outbreak has obviously been causing an increase in numbers, so we've just tried to adapt to that and moved our service into more of the hotels than we were in before. We're just trying to reach as many people as possible and engage with them and see when they're ready. Over this year, we've done 79 tests, and we're a small team, say just 4 pharmacists and support staff, so we're just trying to kind of reach out to people when they're ready and engage with them when they want to. We've been fortunate enough to be part of the WAND initiative as well, so we've been offering the blood spot testing as part of that, trying to engage with people who are injecting, looking at wounds, that kind of thing as well. We quite often find that you'll get people to engage with your service through other parts of the service. So if we're doing a wound check, that'll lead to a discussion about injecting, that'll lead to a discussion about their Hep C or HIV. So quite a lot of things are obviously linked in, which work well for our service, and we just go with the flow and see what the patient needs. We're lucky enough to have really good contacts over with, say, the Brownlee and the Sandyford and Hunter Street. So we basically work with the patients to get them linked in with whatever services. It might be that when we first see them, they're maybe a bit chaotic, not wanting to address their drug use at that point, or their injections, in which case we'll adapt and go with it when they're ready. We try to link patients in with other services and support them to appointments if need be. If say they came back as a positive HIV and they're going down to the Brownlee, we'll try and facilitate that appointment with them, go with them if they need be, transport, that kind of thing. Just basically anything we can do to make it easier for patients to get into treatment and to get things like that sorted. So on to the next slide. So this is just some contact details for our team. So if you need us, just feel free to drop us an email if you've got any questions or want to link in with our service or refer a patient in. We're always available. So yeah, thanks for listening, everyone.
Thank you very much, Rebecca. We're actually just going to go straight on to our last speaker, who is Wendy Cooper from the Health Improvement, who is the Health Improvement Coordinator at Waverley Care, and then we'll have a break. So I'm going to hand it straight to you, Wendy.
Hi folks, sorry, thanks for asking me to speak today. So having a few technical issues there, so apologies. Just before I speak a wee bit about Waverley Care's approach in tackling the current HIV outbreak, a wee bit about Waverley Care and who we are. So Waverley Care, we are a blood-borne virus charity, helping people around HIV, hepatitis C and sexual health in Scotland. So if we could just move to slide 5, please. In 2015, we saw a kind of HIV outbreak amongst Greater Glasgow and Clyde, and particularly the city centre. Some of the contributing factors to this have certainly been poverty, trauma, poor mental health, changes in injecting practice, such as an increase in cocaine injecting. When we've been speaking to folk as well, there's certainly been a lack of awareness around blood-borne viruses and transmission routes, and a lack of awareness around the current outbreak. So with this in mind, education has absolutely been key in making sure people have got correct information, up-to-date information around HIV. There's still quite a lot of myths out there around treatment and testing. So it's about breaking those barriers down and making sure, as I say, people have got that information at hand. Current social policy, such as welfare, housing and prison reform, have definitely contributed to an increase in street begging, homelessness, and we see quite a lot of people in the streets of Glasgow city centre who are off sleeping. Contact with the criminal justice system, particularly we're seeing and meeting with a lot of males in particular who have been currently liberated from prison. Again, not engaging in services, they're not linked in with GPs, addiction services, they've got no accommodation in place. And they've kind of disclosed to us on occasion that, you know, they've resorted back to all kind of coping strategies and began injecting again. So there's definitely been concerns around the kind of risks around BBV. Can we just move on to slide 6 now, please? So some of the other issues I'm sure you can see here that I've highlighted have created quite a lot of issues for the folk that we support. As you can see from the list, the people that we support face many complexities, which we see significantly affect their overall health and well-being, which again, that impacts on their self-esteem, their self-worth, their self-confidence. Many of the folk that we support have got really kind of unhelpful coping strategies that they use just to kind of survive and get by each day. They've really got there's a history of poor engagement with services, and they really struggle to self-manage what they've got going on every day, and often need that intensive support and guidance and loads of reassurance. And again, you know, people do have the abilities to kind of make small changes, but it's about just kind of teasing that out and working with people, breaking it down into manageable chunks and working alongside them, and making them feel valued, because when we do that, we see an absolute increase in the significance and how that then improves their overall health and well-being. Sorry, can we just move on to the next slide, please? So, sorry, slide 8. Yeah. So our response so far, so in 2018, we were funded by the National Lottery Community Fund to create and provide a service, which is the street support service, very much informed by the people who inject drugs. We're very accessible in the fact that we go to where people are. We look at the whole person, because we often realise that HIV and hepatitis C is very last in the priority list. So we work with people, we identify and meet their individual needs, whilst encouraging and motivating people to link back in with clinical support if needs be. We work with a whole range of partners. Again, this is just to ensure that people have access to all the services they need to live well. The street support service is specific in terms of the folk that we support are living with HIV already, or maybe at risk of HIV. They tend to be homeless or in temporary accommodation in Glasgow city centre. Can you just move on to the next slide, please? So yeah, so some of the support that we offer ranges from practical and emotional support, which can include, you know, just attending hospital appointments with people or other medical appointments they've got on that week, ensuring that we're referring and signposting to other specialist support services where needed. Assertive outreach, a lot of that, the team are in the streets of Glasgow city centre, again, just connecting with folk, constantly just kind of building on those relationships, building rapport and fostering trust. And the good thing about that is people recognises in the streets now, you know, and if they need anything, they'll come up and they'll ask, which is fantastic to see. HIV testing, you know, we've always got our bags, which includes our testing kits, and we offer point of care rapid HIV tests. So it's again another wee prick of the finger, and we can give that person the results there and then in about 10-15 minutes. We also offer people dry blood spot testing as well to test for Hep C. We provide harm reduction when we're out, loads of support and advice for folk. We can train somebody in naloxone, make sure that they know what naloxone is, how to use it appropriately, and, the IEP equipment as well. We've got that in our bags, so if people are needing kind of needle exchange, boils, water, we've got that and we can give that out to folk. Alongside the naloxone and IEP, we provide sexual health advice. We've given out sanitary products, we've purchased pregnancy tests for some of the females with support, and we can give out condoms as well. Sorry, next slide please. So yeah, so while we're out in the street as well in terms of crisis management, some of the team have responded to NFOs, near fatal overdoses, where we've administered naloxone, and we've sat with that person and made sure they're okay until the emergency services have arrived. We've also helped people who have been quite heavily under the influence return back to their accommodation safely. We also have Jenny, who's a women's worker. We know that women, with regards to the outbreak, have been quite disproportionately affected by it, and they've got a whole host of other issues going on. Some in quite coercive control in relationships or experience domestic abuse, and Jenny and the team really support the women to eliminate and reduce these barriers so that they can engage with services better than they have been, again overall improving their health and well-being. We're always out there actively seeking people who have disengaged from HIV services or have stopped taking their ARV medication, again to identify those barriers and offer support to re-engage. We also provide advocacy support to overcome challenges people might have experienced with past treatment regimes. Sometimes when we're speaking to people, they're stopped taking their ARVs because they feel that the treatment that they're on make them kind of poorly. So again, it's encouraging them, it's motivating them, to pick up the phone, speak with their BBD nurse or get them a log-in appointment. Challenge and stigma. The folk we support, they face or have faced quite a lot of societal stigma, and then they're also facing that self-stigma. Again, we touched on it earlier on, how that can impact on somebody's self-worth and self-esteem. And their self-belief, the belief that they've got, their perception is often distorted in terms of how they see themselves and how they see their world. There's a lot of kind of mistrust in services. So if we could just move on to the next slide, please. So again, some of the services, the Outbreak, it's certainly not one service can tackle that alone. So it is collaborative working, and coming together and putting in that effort to tackle the outbreak. So we work with various partners, the NHS BBD staff, the SIMI community, we liaise with IEP manager John Campbell. Some of the services come together once a month at the City Centre Harm Reduction Action Group, and we discuss kind of 6 key strands, which include IEP, naloxone provision, wound care, and we look to develop ongoing resources to make sure the people we support have access to that information that they may need. Sorry, next slide, please. Yeah. So I'm not going to pay too much attention in this because I'm just wary of the time that I've got. So some of the ongoing challenges that we've seen, I've kind of listed them there, but I just want to pay particular attention to the homeless accommodation. We're seeing that quite a lot of folk that we're supporting at the moment have kind of moved from one place to the next within a short period of time, not been given quite, enough time to pack up and move on. Again, sometimes the staff, when this happens, have got their Sherlock Holmes coats on and doing quite a lot of detective work, because a lot of the people we support, they don't have phones, so it's very hard to keep in contact with them most of the time. The Outbreak, originally that cluster in the city centre is now expanding into other areas, so we're looking to make use of the IEP van and possibly start doing some testing drives. With COVID, we can't quite get into pharmacies at the moment, but even if we can use the van and make contact to folk who are maybe undiagnosed, maybe never have been tested, not been tested in a long time, They may have a known diagnosis, but there's some fear in there, there's some barriers there that prevent that person to access the treatment. Sorry, next slide. Yeah. So again, some of the other ongoing challenges I've already mentioned, problem substance use. I think that's the same slide actually. Can we move to the next one, please? Yeah. So in terms of the work, in terms of the service going forward, we just continue to strengthen our working relationships with partner services. Again, working collaboratively with partners to ensure consistency and continuity for people we support. We'll continue to monitor and evaluate our service delivery in order to best meet the needs of people we're there for. And just as importantly, making sure that people we support are visible and their voices are heard. Thanks very much for listening. Thank you.
Thank you very much, Wendy. And thank you to all our speakers on the front lines of tackling the HIV outbreak in Glasgow at the moment. We're going to take a short break and meet back here at 3 o'clock. So I'll see everybody there and we're going to have a question and answer. Thank you.
Great. So we have had a range of questions coming in, and thank you all for your presentations. I think it gave everyone a real insight into the work that's been going on. So just to start with the first question then that's come in, I think, Colin, you maybe mentioned that there was issues with engagement with some of the people that you were working with them engaging with you. And a question's come in asking, what is the issues with engagement, and are clients not willing to engage, or are there other reasons going on? So someone's just wondering if you could expand more on the engagement issue with clients, please.
Yeah, okay, so well, I guess engagement really, people don't want to have HIV, so they don't want to come to clinic, and you know, they're in denial, I think, certainly at the beginning of a diagnosis. So you just have to be persistent, you just have to be there, you just have to keep knocking on the door and trying to get them to come in. And they don't want to be associated with our services either. They don't want to be seen coming to our service because they think, oh well, they're going to be identified as having HIV. So we try to reassure them. We say, you know, there's lots of different people come to all the different clinics. We don't just have an HIV service, it's a bloodborne virus service, so it's HIV and hepatitis C, as well as hepatitis B, obviously. And so I think that sort of helps a bit. And if they're coming in for other reasons, then we can try and engage with them then. So it's not just always specifically to see us. So it's really just because they want to be anonymous. They don't want other people to know the diagnosis. And it's just getting to grips with that initial first diagnosis of HIV and accepting that, yeah, they do have HIV. And part of that is obviously us building relationships with them and explaining what we can do. The treatments nowadays are excellent. They really do work, and they can control the virus. And people can expect to live a normal lifespan with HIV. So we try and be positive and try and get people to engage that way.
Thanks, Colin. Anyone else, Lindsay? Any points on engagement and how we engage with clients if they are struggling to engage? Oh.
Sorry, I unvideoed instead of unmuted. Yeah, I think we're in a similar position to Colin. So, but also we have to view, for sexual health in particular, we want it to be viewed as patient choice, which is always the case for all of our services. But as Colin said, we know this is a patient group that perhaps doesn't engage well with services, doesn't, you know, have maybe had bad experiences with services, and in particular NHS services in the past. So we want to try and give that kind of positive attitude over to them. We want to encourage them to engage with us. And I think it was Becky mentioned as well, sometimes on the first visit, you're just really saying hi and introducing yourself. And then it might be that you meet them one day on the street and you have a chat with them, but then the next time they're ready to maybe come to clinic or come to a more formal setting to discuss what it is that's going on for them. So persistence is the key, I think, but not in an overpowering way. We just want to be able to offer all of our services and help people out as best we can.
And Becky, any points?
Yeah, I would agree with Lindsay and Colin. I mean, when we meet somebody the first time, it might be that they're homeless and hungry, in which case we phone casework, get them housed, get them some food, and then address what issues they want to. It might take 3 or 4 visits. It's just doing it at their pace and sticking with them.
And Wendy, are you there? Anything to add?
Yeah, no, just agreeing with what everybody else has said, Leslie. You know, sometimes we found that. I mean, the street support project have been operating now for 2 years, and actually we've just had somebody who's now willing to engage in addiction services for the first time. You know, so sometimes it's about persistence and just chipping away and being there and acknowledging that maybe now's not the time, and just leaving folk to that time when they're ready to engage, you know, and just being there as a support and reassuring folk.
Thank you. Next question that we have come in is about the 95% viral suppression on treatment, Colin. So I think this was a stat that you said during your talk. So I think someone was just saying, what's that 95% a number of? Whether that's, yeah, I'll let you answer.
I better turn my mic on. Okay, yeah, so I think so far this year we've got 95% of people that are achieving viral suppression. So actually we're doing not too badly in our group. So there is the World Health Organization has got this 90-90-90 target, where you say 90% of people who've got infection or HIV infection know that they've got an HIV infection. 90% of those people are on antiretroviral treatment, and 90% of those people again have achieved viral suppression. So actually we're doing pretty well. We've got, well, for the first part, I don't know if 90% of the PWID population who've got HIV have been identified. That would really come from public health. They'll have a better insight into that. But certainly the other 2 points, more than 90% of the people who have HIV are in fact on medication for it. I think it's closer to 100% to be honest. And of those people, we're achieving a virus suppression in up to 95% of those. So I mean that's a real success for us. I think we're in line with the World Health Organization and the rest of the UK really in achieving the 90-90-90. Although I do believe that these targets are going to get even tighter as the years go on. So that was really it. So viral suppression, we want to achieve viral suppression. So we're looking at less, to be undetectable, you've got to be less than 40 units per ml, but actually we're measuring at 200. So if it's 200 or less, then it's less likely to be transmitted sexually, absolutely. And it's the same thing applies to drug use. So treatment as suppression, as prevention rather, treatment as prevention. So by suppressing the virus, it's less likely to be passed on to other people.
And that's 95% of the cohort that you're looking after, that 130 number of the people that you're looking after in your care, in your caseload.
That's right, yeah. It's that now, yeah.
Thank you. I'll move on to another question, and we have a few questions about testing. One is anyone aware of the testing that you are doing, what the percentage positive rate is, like how many positives you get out of the whole number of tests that you are doing? No.
I don't have an actual figure, I'm afraid. We know the percentage population, which is a figure that is publicly available, of the PWID population in Glasgow is around 10% are known to be positive for HIV at the moment. But I'm not sure, sorry, what the actual figure of positivity is in all the tests that we do. Because between all the teams, we do hundreds and hundreds of tests a month.
Yeah, thank you. Anyone else got any other points to add in there? Will I move on to the next question? I'll move on. Someone's asked a question about stigma. Stigma's been mentioned within the presentations. And what do you think the causes of continued stigma around HIV are? And has anyone had any or heard any experiences from patients and people that you're looking after around the stigma that they've experienced being diagnosed with HIV? Lindsay, do you want to come in first?
Absolutely, it's definitely out there. I think among our cohort and among our population that we're working with, the levels of knowledge around HIV are low. It's not something that they've come across. It's previously been that hepatitis C became a little bit normalised within the population, and they felt they got to a point with each other where they were talking about it. They were openly saying, I'm hep C positive. They were maybe avoiding sharing injecting equipment and things like that with each other. But HIV seems and still seems completely different for them. Most of them do not disclose their status to each other, which is tricky. For us, tricky from a transmission point of view, because if they're in a situation where they are perhaps all using drugs together, they're maybe not being open about not sharing any of the tools involved in injecting drug use. In terms of sexual contact, they can be slightly diminished by drugs and alcohol in terms of safer sex and looking after using condoms and things like that. So, but definitely the stigma is there. As Colin mentioned during his talk, they hardly want to even come to the clinic at times because they think people associate. We are very small teams, and I think what our team and the BBV team we are very aware of is that we are known now as well for being connected to the HIV outbreak, and perhaps if we're talking to people, we want to be able to make sure that that's as private as we can make it if we're out and about as well.
Thanks, Lindsay. Wendy, do you have any points that you'd like to come in on?
Yeah, again, just agreeing with the other speakers have said, Leslie, but you know, it's kind of what I've certainly seen is even in services, you know, even if it's not true, there's a lot of speculation in services regarding you've got folk judging other folk, you know, and coming up with the assumption that that person is living with HIV, and they're then kind of discriminated against, you know, and kind of ostracised from that group, whether it's true or whether it's not.
Yep.
You know, so people in services are even facing that, you know.
Thanks, Wendy. And Becky, any points to add in?
I just feel like people obviously like to keep their health private, and they do just worry about being judged, especially in some of the hotels where there could be over 100 people all living in the same space. As soon as they'll worry that when one person finds out, they'll pass it on. And it is just that feeling that people worry they'll be judged, whether they're positive or not, people talking about their health behind their back, that kind of thing. Just it's a cause of concern in big areas like that.
All the teams, sorry to come in, all the teams as well, though we do work really hard with the patients to try and normalise chronic infection a wee bit. This is a long-term chronic health condition that we want them all to be able to access help and care and support in the same way that they would for instance, diabetes. But you're right, it's the stigma is the barrier at times to accessing that care. So we do work hard to try and normalise it in terms of chronic disease management rather than HIV.
Thank you. So we've got a question that's just come in. I think when we looked at the time to get onto treatment, the antiretroviral treatment, Colin, I think it was a graph that you shared. They were just asking for why there was such a long wait at the beginning. If you could just talk a little bit, especially in 2015, just say a bit more about the length of time it took and why that's lower now.
Okay, yeah, I mean, it did take longer to get onto treatment at that time. And a lot of that was down to, well, what we've been talking about, people not engaging with services, people not wanting to come to services. And obviously at that time, services were limited to one place. It was, you had to come to the Brownlee, you had to come to the hospital, and that's where you would get your treatment, and people just didn't do that. So how have we improved that? Well, we've improved that by doing what we're doing now, basically outreach, working with this team that you can see in front of me here, the third sector, sexual health, pharmacy. This is how we're actually improved access to our patients, and getting them to actually come to our clinics, which are closer to them. So we brought our clinics closer to them, and we can actually go to their accommodation and invite them to come with us. We can even provide transport if need be. So I think that's how we've improved the duration from diagnosis to actually starting treatment.
Thanks, Colin. We have a question that's come in asking about I think Lindsay and also Wendy, you discussed about the services specifically for women, and just asking a little bit more about what percentage of women make up the cohort. And also just added on at the end of that question is the same services available to men that are, so the sexual health services, etc., to men, and as the engagement there. So Lindsay, we'll come to you first.
I'm not sure of the exact figure of women, but I can certainly get that for you, and I should be able to get it for you by the end of this session if I can get that answer. It is disproportionate though, as Wendy said. We do have proportionally more women. We don't have more women than men who are diagnosed HIV positive, but in terms of women who are injecting drugs and engaged in addiction service, it is more proportionately more women are affected by HIV. We know that's for a variety of reasons. Unprotected sexual contact, women are more likely to perhaps develop HIV from a positive male through that way. Injecting drug use, there are complexities around that a lot of women that we come across don't inject themselves, so they are injected perhaps in groups, or they're injected by partners or other people that are around them, and that can often mean that they're not first to use the drug either. So perhaps they are then using needles or syringes or spoons that have been used by others before them. Absolutely, our sexual health services are available to men and women equally. We engage with many men, and as I said at the start, sexual health is predominantly not something that men, unless there's a problem, will seek help for. So if they develop symptoms, men are likely to contact sexual health services or their GP. But in this cohort, what we were finding, especially at the very beginning, was men had perhaps had symptoms, especially genital symptoms, that they hadn't talked about for years, and also in particular past sexual trauma. It wasn't something until we were openly asking questions around childhood sexual abuse that men were opening up to us, and we were perhaps being the first person that they'd ever talked to about that. So we were able to offer support and then ongoing support through different services. But no, absolutely, we offer the same service to both men and women.
Thank you. Wendy, would you like to come in?
Yeah, the same, Leslie. The services that we offer are open to anybody that's looking for that support. In terms of women, what I'm seeing is more women engaging. You know, normally it was predominantly males that we've seen. That still is the case. There's a higher number of males engaging with the service, but however, we are starting to see more women coming forward and seeking that support.
Thanks, Wendy. I'll move on to the next question. So we've got a question here, I think just following up from the conversation about engagement that we had on the first question. Just a query about engagement. Are services flexible with regards to non-attendance for the population that we're looking after? Lindsay's smiling there, so we'll go to you
Absolutely.
first.
Yeah. If they don't attend, we always follow them up. I think, as Becky mentioned earlier, these people, our clients, our patients, have so much else going on in their lives that their health is usually not their priority, and especially you know, it might not be their priority on the day that they're due to see us. The other thing that we have very quickly evolved to is we don't really do appointments unless someone actually wants one. Most of it is ad hoc, most of it's walk-in or drop-in, or your best opportunity to see someone is when they present in front of you, and that's your biggest opportunity to get whatever you want to talk to them about done at that time.
Thank you. Colin?
Yeah, so people don't come to their clinic appointments like they're supposed to. That's a pretty normal thing. So we will outreach to these people. If they've missed a clinic appointment, then we'll try and get them on outreach, and we'll also give them another clinic appointment to make sure that they don't fall off our radar. And even if they're not on our clinic, but they've happened to turn up that day, then we'll get them in and we'll see them. Either they'll see either a nurse or a consultant. We're all very flexible. We just want to see our patients and make sure that everything's going okay for them. So we take whatever chance we can to actually see them and update bloods if we need to update bloods and talk about the medication to make sure that everything's going okay. So any chance we can, we try and chase them up. We definitely don't lose these patients. We keep trying to get them, even if they're not turning up.
Thank you. Becky, any?
Yeah, patients are never closed to our service, so if they wait weeks or months and they present back, then yeah, we get them linked straight back in. If they come to see me for their asthma, and I noticed they've missed an appointment with Colin, quick phone call, linked straight back in. It's good that we can work as a team so well, so it's great for partnership working. So they're never off the radar.
Great, thank you. We've got a question on how do you find the level of awareness about HIV amongst the people that you work with? So the clients that you're working with, is there awareness about, Colin, you mentioned U equals U, undetectable equals untransmissible. Is there awareness about the increased transmission going on as well? So just where's people's knowledge that you're working with, I suppose? Becky, do you want to come in first this time?
Yeah, it's very variable, I guess, depending on the age of the person you're working with, their injection history, and I guess sometimes who taught them. Sometimes you'll find that if they've been doing it for a long time, maybe get more awareness, but if they're quite a new injector, they might not be aware of all the routes. Like the majority will know about needle sharing, but they might forget about syringes and spoons and all the other kind of paraphernalia that go with it. And we just think it's very variable, and we cover teaching as part of our sort of health check. So we just go through all the routes of transmission and see what they know and educate them on any gaps that they might have, but definitely seems to be quite variable.
Thanks. Colin?
Yeah, what Becky's saying is right. There is a large variance in people's understanding of HIV. That's amongst our patients and also amongst our colleagues that we work with. I mean, there's quite a varied understanding of HIV. A lot of people, when they're first diagnosed, they still think it's that death sentence. They're coming in and their days are numbered, but that's really not the case. So we do spend a lot of time when people are diagnosed, and even years down the line, we keep reaffirming the message that actually HIV is a long-term condition. You know, it can become untransmittable. You just have to basically take the medication, and your lifespan will be, you know, a normal lifespan. So it's certainly there is a lack of knowledge out there in the injecting drug using population, but also, you know, amongst the health professionals. I mean, and we always try to teach our fellow health professionals. There's always talks going on. We have talks for students as well. So we just need to keep trying to promote that message, and in so doing, that's going to help to battle against stigma as well.
Thanks, Colin. And Lindsay?
Yeah, I would obviously agree with those points. Wendy mentioned the harm reduction action group. So once a month, all the city centre outreach teams meet. So where there may be this a lack of knowledge, as Becky said, particularly around new injectors and younger people. They're certainly not within the core city centre services. So I would be surprised if it would be very quickly that you would perhaps meet a service and they wouldn't be mentioning the HIV outbreak to you and using these harm reduction messages that we're all using about protected sex, clean injecting equipment, you know, getting onto ORT and things like that. So yeah, certainly within our core teams, we all work really well together and have developed this network where we're really getting the message out there.
Thanks, Lindsay. And Wendy, anything
So,
to add there about? Yeah.
No, I agree with what everybody else has said, Leslie. What we found though is, you know, education is still very much key in getting those messages out there. We find that a lot of people sometimes they get a wee bit muddled up in terms of Hep C information and HIV information. So sometimes they know bits and bobs here and there, but they'll confuse the two.
Yep. Thanks, Wendy. Just to add on to education, SDF has just launched a new e-learning, and it will be in the link to for an evaluation after this, so everyone will have access to that. Just a little self-plug there. Lindsay, we have a question about the contact tracing that you mentioned, and it is, how many people have you identified through contact tracing that's been, are you able to share any of that information?
I don't have an exact figure to date, but the last I heard, which was perhaps about a year ago, we had identified over 400 contacts. And as I say, we do our absolute best to make sure. So if the patient themselves is informing contacts, then we always follow that up with checking notes to see if that person has tested. If we are doing it ourselves, then we never close anybody off until we've managed to engage with them and have enabled them to be tested for HIV and have some support around that if they're negative or positive. But it's hundreds and hundreds, and we have identified quite a few positives as well through the contact tracing.
Thanks, Lindsay. And Lindsay, sorry, you've got another question as well, and this one is, what's it been like being out in the van, and how different is it working on the van and doing your work that way?
The van was brilliant. I think we all found that when we were in the van. It was only different in that you're at the side of the road, because once patients were in the van, it is fantastically designed into a clinical space. So we had everything we needed. We carried all our own stock, and the work is the same. So again, it's just for us to realise that what we're doing is exactly the same as we would do in any other setting. It's just that we were doing it in a much more flexible way. There were obviously limitations as to what we could do in the van. We couldn't do genital examinations, we couldn't fit contraceptive implants, but we were able to easily and quickly identify people who needed them and signpost them to where they could get that done, either through us or through Sandyford services. But it was brilliant, and it's definitely something that we have continued to do and will continue to utilise even after COVID.
Thank you. Just having a little look here. Someone's asked the question about, there seems to be all the different teams are doing lots of different testing, and is that being cross-referenced? I suppose in some way someone has asked, has one person got oversight or one agency got oversight of all the tests being done? Who'd like to come in?
I'll come in. Well, just the first point is that we don't have anyone that oversees all of the testing, but we do have what's called a fail-safe system, and that's where every positive HIV test across Glasgow comes to a central point within Sandyford, and if that person is known to be open to addictions or is known to be PWID, then that information is passed to me and the team, and we follow it up that way. So we absolutely have a very robust system where diagnoses are not missed, but no one person has a oversight over all of the testing that happens across the city.
Thanks. Anyone else got any points to add there? We'll move on to move on to another question. One other one about awareness and knowledge. Do you think that more could be done to inform the general public around what's going on with the outbreak? Don't know if anyone's got any thoughts there. Colin?
Okay, so well, I think things like, you know, World AIDS Day is the ideal opportunity to try and get information out there to the general public. I mean, there was a big drive in the 80s, obviously, with the tombstones and everybody thinking that we're all going to die of HIV, and some people are still stuck there, I have to say. So yeah, there needs to be more of an effort, I think, to try and inform the public. And I think the platforms to do that are through, you know, media, through, you know, all the different apps that people have got, Facebook, etc. I think we should be utilising these to try and get more information out with regards to HIV. And I know that 10 Seconds Trust do messages on Facebook, so I think that's helpful. But I think there could be more done. I mean, you do see adverts on the subway and at different times of the year, but it just seems to be every now and then there seems to be some publicity about HIV. So yeah, I think there definitely could be another push to try and get the message out there.
Thank you. Anyone else like to come in there? Got two more questions. Oh, on you go, Wendy.
No, it's fine. Sorry, I was just going to come in, Leslie, and say I totally agree with what Colin said. There is a lot of social media plays a big part in terms of getting those messages around HIV out there. However, you know, I totally agree that people are still stuck back in the 80s. And also, I think it's important to get that message out there that HIV doesn't discriminate. Although we work with very particular populations, it's about also letting the public that it doesn't discriminate, you know, and everyone could be at risk of HIV. I don't think we do enough of that.
Thank you, Wendy. So we've got two more questions. One is, has PrEP been used as a prevention tool for people connected to the outbreak? Lindsay, will I come to you first on that point?
It's not being used as a primary prevention tool because at the moment there is a lack of evidence around solely using PrEP in injecting transmission risk. So that is why we haven't offered it to everybody. So there has to still be, under the NHS eligibility guidelines, there has to be a sexual element to the risk. So as I mentioned before, because of the prevalence in the city centre, that does now include someone who is injecting drugs who may be having sexual contact with someone else who injects drugs and their status is unknown. It involves anyone who is involved in transactional sex, so sex, men and women who are involved with sex for money or drugs or accommodation or anything else, and also the partners of people who have been diagnosed with HIV.
Thank you. Any other person like to come in there? I think Lindsay's, you deliver that service, don't you, Lindsay? Yeah.
Yeah.
So the final questions, but I'll ask them to two questions, but I'll ask them together. We're coming into winter, and is there going to be any contingency plans for delivering the services that you do during winter? I'm sure you've already delivered them through winter, but the other question is about COVID. But I suppose if we have other lockdowns and then it's winter as well, so both winter contingency and then COVID during winter contingencies for the next few months. So Becky, we'll come to you first.
Yeah, I mean, we just, as soon as lockdown the first time happened, we didn't really have any downtime. We just got loads of PPE, built screens and went straight back out, and then we expanded our outreach. So the more hotels that maybe are used, the more we'll go into. So we'll just adapt to where the people are. If they're in hotels, we'll be in hotels. If they're on the streets, we'll go out and walk. If they're coming into the hub or the mini trust, we'll just see them there. So it's just wherever people are, we'll just adapt and visit them where it needs to be. We're flexible, so it's good.
Thanks, Becky. And Colin?
Yeah, I think since the COVID outbreak, the good point has been that people have been offered accommodation in all these different hotels within Glasgow. And that's actually made our job, I think, a little bit easier because we can track down our patients a bit more easily. We know where they are, or if we don't know where they are, then one of our colleagues within the third sector will probably know where they are. And now that winter's coming in, this is going to continue. People are still going to continue to be housed, and we're still going to know where they are. So hopefully, going through the winter, it should be much the same, really. I think the difference is the lockdown situation, and while this is ongoing, I think it's going to be the same. People are going to be accommodated, so that's a good thing.
Thank you. I'm going to bring Wendy in just now because I don't know whether Wendy's moving on the mic. I'm just hearing it. So Wendy, have you got any points to add about winter and also COVID contingencies?
In terms of COVID, Leslie, I mean, we'll continue. We're approaching Christmas, so in terms of service delivery, some of the staff might be working here and there through the festive period. I know a lot of the staff are taking a well-deserved break for a couple of weeks. However, you know, we'll just keep continuing to do what we're doing, Leslie. You know, we've got loads of kind of frameworks and policies in place now. Staff have got all their IEP equipment in place, and we're trying our best just to stay within that protective bubble, if you like, to continue to be out there and continuing with the work that we do.
Thanks, Wendy. And Lindsay?
Yeah, we're exactly the same. Loads of PPE, and we're out and about. And this is what generally works for outreach teams anyway. We're really good at getting out there and finding who we would like to find and offering our services to everybody who would benefit from them. We will continue undeterred.
Thanks, Lindsay. That's the questions all finished. I'm going to see if Fiona can rejoin us. Hi, Fiona. Hi, Fiona.
Hello.
Welcome back. I'm going to pass over to you. Do you have any, just for final comments on any of those questions to add in and final remarks? Thanks, Fiona.
No, I had questions and they were all answered by people asking. So, yeah, I'd just like to thank Rebecca, Lindsay, Wendy and Colin for those presentations. And just to let everybody know, all of these have been recorded, so you can access them on the Scottish Drugs Forum or Waverley Care YouTube channels. And you can also see all the other webinars there. And also there's going to be an evaluation that pops up, so if everybody could fill that in. And yeah, I think, thank you everybody, and keep doing what you're doing.